This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub Podcast. I'm Dr. Aris, a senior attending in Pediatric Neurosurgery.
And I'm Dr. Elara, a research fellow. Today we're looking at a fascinating new study from the journal Child's Nervous System, published in 2026. The paper is titled, "To Improve is to Change, but Is It Safe? A Single Surgeon's Transition from Lateral to Vertical Hemispherotomy."
It's a provocative title, Elara. We often talk about the learning curve in residency, but we don't talk enough about the learning curve for established, experienced surgeons adopting new techniques. In this case, we're talking about hemispherotomy for drug-resistant epilepsy, or DRE.
Exactly. And as we know, about 1 in 3 children with epilepsy will become refractory to anti-seizure medications. That DRE carries a heavy burden: cognitive regression, poorer quality of life, and even early mortality. When there's a hemispheric abnormality, whether it's a congenital lesion like hemimegalencephaly, a progressive disorder like Rasmussen's, or an acquired insult like a perinatal stroke, surgery is the gold standard.
Right. We've moved away from the old-school anatomical hemispherotomies described by McKenzie and Crenal in the 30s and 50s, largely because of the long-term complications. Modern practice is all about hemispherotomy, functionally isolating the hemisphere by transecting the commissural fibers and projections while leaving the brain tissue mostly in situ.
This paper focuses on the 2 main flavors of that functional disconnection, the lateral perisylvian approach and the vertical parasagittal approach. Dr. Aris, for our residents listening, how would you describe the fundamental difference in the view between these two?
Well, the paper has a great diagram, Figure 1, that lays it out. The lateral approach is the traditional, widely practiced one. You're going in via a peri- or transsylvian route. You're looking at a suprasylvian disconnection, an insular undercut, an infrasylvian and temporal disconnection, and then the corpus callosotomy. It's effective, but it's a lot of work around the sylvian fissure.
Whereas the vertical parasagittal method, which was developed more recently, uses a superior frontal gyrus window to enter the ventricle. From there, you perform the corpus callosotomy, the insular undercut, and the temporal disconnection from a superior vertical trajectory.
And the literature has been leaning toward the vertical approach lately. The authors mentioned the FALA study, a post-hoc analysis of the HOPS data, which suggested that the vertical method might actually produce better long-term seizure freedom and require less cortical resection, less time, and result in fewer blood transfusions.
That's the "to improve is to change" part of the title, but the "is it safe" part is what this study investigates. They looked at 36 patients operated on by a single surgeon between 2016 and 2025. 23 underwent the lateral perisylvian approach, and 13 underwent the vertical parasagittal approach.
This is a classic transition study. The surgeon started with the lateral technique and then moved to the vertical. They wanted to know, does the surgeon's learning curve during this transition put the patients at risk? Did the seizure freedom rates drop, or did the complications spike during the switch?
Let's look at the patient demographics first. The etiologies were what you'd expect: cortical dysplasia, stroke, Rasmussen's, and Sturge-Weather. To keep it fair, they used the HOPS variables, the hemispheric outcome prediction scale, to see if the groups were comparable.
For the residents, remember those HOPS predictors: age over 3.5 at seizure onset, stroke etiology, no previous resective surgery, no generalized seizures, and no contralateral hypometabolism on PET. The authors also mentioned MRI findings and the presence of contralateral interictal activity on EEG as predictors.
So when they compared the lateral group to the vertical group, what were the big takeaways?
First, the primary outcome, seizure freedom. At 1-year follow-up, 90.9% of the lateral group were angle class 1, meaning seizure-free. For the vertical group, it was 83.3%. Statistically, there was no significant difference, a p-value of 0.602.
That's crucial. It shows that even during the transition, the surgeon maintained high levels of seizure control. But where the vertical approach really shone was in the perioperative metrics.
Yes, the numbers here are quite striking. The mean operative duration for the vertical group was 340.9 minutes. For the lateral group, it was 448.8 minutes.
That's over a 100-minute difference. For a pediatric case, 100 minutes less under anesthesia is significant.
And it wasn't just time. The intraoperative hemoglobin drop was significantly less in the vertical group, 18.1 grams per liter, compared to 27.2 grams per liter in the lateral group. The p-value for both operative time and hemoglobin drop was 0.002. That's a very robust finding.
It supports the idea that the vertical approach is less invasive in terms of cortical resection and blood loss. What about the hospital stay?
Interestingly, the mean hospital stay was almost identical, 8.7 days for vertical versus 9.8 days for lateral. And the complication rates showed no statistically significant differences. They were able to transition without an uptick in morbidity.
I found the chronological epoch analysis particularly smart. They split the patients into groups based on when they were operated on, to see if there was a dip in outcomes during the transition period.
Right. They used a binary logistic regression model to look at seizure freedom by epoch while controlling for all those Hops factors we mentioned. They found a p-value of 0.816, meaning there was no significant difference in seizure freedom over time. The change didn't cost the patients their seizure control.
So if the vertical approach is faster and involves less blood loss, and the seizure outcomes are the same, should everyone just switch tomorrow?
The authors are careful there. They conclude that while the vertical approach looks favorable, the most important thing is that an experienced surgeon can transition safely. They suggest that it's useful for a surgeon to have a sound grasp of both techniques in their armamentarium.
That makes sense. Sometimes patient anatomy might favor one over the other. If you have a patient with specific distorted anatomy, having both the lateral perisylvian and the vertical parasagittal roots in your toolkit is a huge advantage.
Exactly. The study is a single surgeon series, which is a limitation, but it's also its strength because it eliminates the inter-surgeon variability factor. It shows that the learning curve for a senior surgeon doesn't have to be a danger curve for the patient, provided the surgeon is already experienced in the principles of hemispheric disconnection.
It's an encouraging message for the senior attendings out there who might feel locked into the techniques they learned in fellowship 20 years ago.
To improve is to change. It's a Churchill quote, I believe. And in this case, the change seems to lead to shorter surgeries and less blood loss without sacrificing that 80 to 90% seizure freedom rate.
Just to recap the technical highlights for our listeners, the vertical approach uses that superior frontal gyrus window. The authors describe it as a way to enter the ventricle efficiently to reach the corpus callosum and then move down for the insular and temporal disconnections.
And for the lateral approach, remember the 5 key steps mentioned in the paper: suprasylvian disconnection, insular undercut, infrasylvian disconnection, temporal disconnection, and the corpus callosotomy. It's a more circumferential approach.
This study really highlights the evolution of pediatric epilepsy surgery. We've gone from removing the whole hemisphere to these precise functional disconnections that can be done in under 6 hours with minimal blood loss.
It's a great piece of work by Salim, Chari, and Tahir. It's a reminder that even when we are masters of a technique, we should always be looking at the data to see if there's a safer, more efficient way to achieve the same goal.
Definitely. And for the residents listening, pay attention to those HOP scores in your pre-op rounds. As this paper shows, regardless of the technique, those underlying factors, like etiology and PET findings, remain the strongest predictors of whether your patient will wake up seizure-free.
Well, that's all the time we have for today's deep dive. Thank you for joining us on the Neurosurgery Hub Podcast.
We hope this helps you in your next epilepsy case. We'll see you next time.
Stay sharp. Outro music fades in.